I'm Brooke Spencer. I'm one of the moderators, and I wanted to thank Venk for having me again. I always find this meeting to be really amazing. That last session was incredible, but I don't do arteries. So I'm going to talk to you guys a little bit about iliac vein stenting for POTS and pelvic pain. I know this might be off the beaten path for some of you. Can the IT guys, can you start the clock again? Okay, so I've been working with Alexis Cutchins, who's a cardiologist at Emory, who is a national referral center for patients with postural tachycardia, which is an increase in heart rate of 30 beats per minute when you stand for a prolonged fashion, but without hypotension. And many of these patients also have orthostatic intolerance. It's kind of a whole spectrum, and they get very, very dizzy, lightheaded, and presyncopal. And if you look at a quality of life survey out of Mayo, their quality of life is similar to that of people with CHF and COPD, but the average age in our patient population was about 36 years old. These patients are very interconnected with multiple other complex disease processes, including mast cell activation, autoimmune issues. We're finding that COVID, Lyme's disease, Bartonella, Babsiella are triggering these things. Cognitive dysfunction and chronic fatigue, small fiber neuropathy, and a number of endocrine issues. So there are a few studies that have looked at minor case series of people with connective tissue disease in POTS that responded to stenting. Grace Knutson at Mayo Clinic here in Scottsdale and Steve Smith looked at age-matched controls on CT for blinded radiologists in patients with POTS versus renal donors and saw a significantly increased incidence in iliac vein compression in the patients with POTS. If we look at the Santoshi article that was published in 2018 in a large number of women sent for pelvic congestion, they found that 80% of them had more than a 50% stenosis in the iliac vein. And when they treated the gonadal vein first, they didn't respond. But when they went back and switched to treating the iliac vein first, the majority of them responded in terms of pelvic pain and dyspareunia. We published an article in the Journal of Phlebology earlier this year or last year of 25-year-olds, 30 of them with pelvic pain showing a statistically significant improvement in pelvic and urinary symptoms at 3 months that lasted out to a year because there's a lot of concern about stenting these young patients, and we're going to be doing a 5-year follow-up soon in about another year on those patients to see where they are. And in Dr. Cutchins' population, she showed that 75% of her patients had lower extremity venous insufficiency and 77% pelvic venous disease, and that's now up to about 94 since they've learned how to look for it a little bit better. In a meta-analysis looking at 1,100 patients with nivel lesions, they showed that the primary and secondary patency rates at a year was 96 and 99%, so not as bad as the post-thrombotic patency rates. And we're talking about people with pretty advanced iliac vein compression, although not all of them show a complete epidural venogram with resolution after stenting. So we're submitting this article for publication. We either did on Friday or we're doing it on Monday. We looked at a retrospective review of 271 female patients with an orthostatic hypotension score of greater than or equal to 3, which would be suggestive that they have orthostatic hypotension or POTS. The average age was 36 years with a standard deviation of 13 years, and they were all successfully treated. All had greater than 50% stenosis of the iliac vein, but the average compression was 78% with a standard deviation of 9%. The OHQ score consists of 2 different components, a symptom score and then an activity score that looks at symptoms, obviously, and their ability to do activity, but the activity score requires hypotension for it to be calculated, and a composite score is the 2 of those. Greater than or equal to 3 is considered positive, and so we took those patients out of our 1,000-patient stent population and studied them and saw a statistically significant improvement in their OHQ scores at 3 months that lasted out to a year. And what I thought was interesting is that while not all of these patients respond because they have all this multifactorial disease, that at 1 year, 71% of them showed what was considered a meaningful indication of change in their scores, and 44% of them actually had a score less than 3, suggesting they no longer met criteria for POTS or orthostatic intolerance. When we looked at their International Pelvic Pain Society score and their pelvic congestion scores, we saw a statistically significant improvement at 3 months that lasted to a year. And then we looked at their PUF, which is the pelvic pain urinary frequency urgency score. Both the bother score, the symptom score, and the composite score all showed a statistically significant improvement at 3 months that lasted out to a year. An ancillary symptom score was created by Steve Smith from a Facebook group of patients with pelvic pain over years saying they had all these other symptoms. We have some adaptation of that, and that showed improvement at 3 months out to a year as well. And more importantly, when we look at the patient's global impression of change at a year, we see that 80% of people felt they had a significant improvement. 10% didn't really feel they had any significant improvement, and 10% continued to get worse. So it's not perfect, but in a disease process where conservative measures of vascular volume maintenance and salt diets and compression don't really work very well, it's a pretty big win. We also went back and tried to look at what the frequency of other symptoms related to patients with orthostatic hypotension was, and 96% of them had pelvic pain and heaviness, really high incidence of lower GI symptoms, low back pain, urinary urgency, frequency, dysuria, and presyncope. But you can see there are lots of other things associated, and about 35% of our patients had hypermobile connective tissue disorder, so that's pretty high proportion given the relative rarity of that disease compared to this population. The other thing I think is super important, if you hear nothing else out of this talk, learn this one. 55% of our patients had bilateral lower extremity pain, which means 45% of patients had no lower extremity pain or symptoms. And only about 13% had unilateral left leg pain. So lots of the patients come to me from all over the country and say, I talked to a vascular specialist. They won't touch my iliac vein because I don't have left leg pain and swelling. It's not relevant when it comes to orthostatic hypotension and pelvic pain. I find this super interesting. Harvard just published this retrospective cohort of patients with Hitch and POTS, and Hitch is a mouthful. It's a hypocapnic cerebral hypoperfusion, which means when you tilt the patient up, they have low carbon dioxide levels, and it's on this spectrum with POTS, and they looked at invasive cardiac studies retrospectively, as well as doing a tilt table capnography and also transcranial Doppler, looking at the velocities in their middle cerebral artery. And what they found was that there was reduced orthostatic cerebral blood flow velocities by 19% in the POTS and the Hitch patients, and an end-tidal CO2 with tilt table, mimicking kind of hyperventilatory physiology. They had preload failure, they had mild autonomic failure, and many of them had small fiber neuropathy. So their conclusions were that reduced cerebral blood velocity is due to hypocapnic-induced cerebral arterial vasoconstriction, and that brain hypoperfusion related to ischemia may drive central sensitization, identified in the majority of HITS and POTS patients, and we think that that can lead to increased pain response as well. Similarities in the peripheral domain abnormalities that affect the heart rate suggest that the orthostatic tachycardia is driven by CNS overcompensation for orthostatic changes. And then this is where they almost got it right, I think. They said they think the preload failure can be due to increased venous capacitance and venous pooling. And the part where they say associated with small fiber neuropathy and hypovolemia is the part that I wonder whether maybe it's associated with iliac vein compression, with lower extremity venous insufficiency, with venous pooling in the pelvis. And we really need to go on and prove that. So we've designed a study where we're going to look at 20 patients. We're going to do right heart caths. We're going to do wedge pressures, measure all their right heart pressures, measure intravascular volume of the IVC before and after stenting, and then do the capnography and tilt table tests before, after stenting, and at 3 months to see if we can prove that this is the physiology behind why these people are getting better or not. But ultimately, there are a lot of young patients with debilitating pelvic pain and orthostatic intolerance that really aren't getting treated. They're getting shamed. They're getting sent to psychiatrists. And we saw a significant improvement in pelvic pain, bladder symptoms, and orthostatic symptoms with iliac venous stenting. So I think we need further randomized controlled sham trials, and we need better objective data. All right, that's it.